Coming up on Mayo Clinic Q&A.
PAD stands for Peripheral Artery Disease. What PAD is really talking about is in the arteries down to our legs, having those arteries impacted by cholesterol buildup that leads to narrowing that can be mild, or it can really be severe and can be associated with this, what we consider a leg attack, where you have this sudden clot that forms in the setting of that cholesterol buildup, which is really a life and limb-threatening emergency.
PAD can occur from several factors, including a family history of heart disease, high blood pressure, high cholesterol, or diabetes. Lifestyle changes can help improve symptoms, especially early during peripheral artery disease.
There are several parts to treating PAD: controlling blood pressure, finding those pathways that are going to help them stop smoking. What we eat matters. Mediterranean diet, all those good omega-3 fatty acids, that matters. Supervised exercise therapy, or SET, really as a first-line treatment, oftentimes even before considering revascularization, because it's so successful.
Welcome everyone to Mayo Clinic Q&A. I'm Jason Howland, sitting in for Dr. Helena Gazalka. Peripheral artery disease, or PAD, affects almost 10 million people in the US. PAD usually involves the lower limbs and leg pain caused by reduced blood flow due to the narrowing of the arteries. Unfortunately, peripheral artery disease has not traditionally been diagnosed early enough, and patients are often not treated with the most aggressive therapies. But a new PAD action plan, spearheaded by the American Heart Association, is hoping to change that. Joining us today to discuss is Mayo Clinic cardiologist, Dr. Amy Pollak. Welcome to the program, Dr. Pollak.
Oh, thank you for having me.
Well, let's start out with the basics. What is PAD and what does it lead to?
Oh, absolutely. It's a great initial question. So PAD, as you mentioned, it stands for Peripheral Artery Disease. And that's kind of a mouthful in terms of when we're used to be thinking about things like heart attack and heart function and stroke, and those are much more tangible and easy to digest. But what PAD is really talking about is in the arteries down to our legs, having those arteries impacted by cholesterol buildup that leads to narrowing that can be mild, or it can really be severe and can be associated with this kind of what we consider a leg attack, where you have this sudden clot that forms in the setting of that cholesterol buildup, which is really a life and limb-threatening emergency. And so PAD can run that spectrum of, asymptomatic cholesterol buildup in the arteries to the legs and feet, to cholesterol buildup that's impacting blood flow that patients feel with some variety of symptoms that we'll talk about, to really this kind of acute change where it's really threatening to the integrity of their limb.
You mentioned the term leg attack. So is it similar to a heart attack? Is that why it's called that, or is it completely different?
So it's similar in the sense that for many heart attacks, that underlying pathophysiology is cholesterol and plaque, atherosclerotic plaque mediated, and that you tend to have a clot form in the setting of that underlying atherosclerosis. So that same pathophysiology can occur in the blood vessels to the legs. And if you have that sudden occlusion of one of the arteries to the legs, you're understandably not going to get blood flow distally. And all of that muscle in the and tissue in the foot and leg is going to be impacted and at risk. And so that, in kind of medical words, would be an acute leg ischemia or acute limb ischemia, ALI. But I think leg attack is really that phrase that seems to understandably resonate with most people.
So essentially, the limbs, the legs, are not getting enough blood flow.
You're exactly right. And that can happen suddenly, that acute limb ischemia or acute limb event. And it can also happen more chronically. And that's where you start to see sores that aren't healing on someone's foot. There's a high crossover when patients have diabetes and diabetic foot ulcers, or that change in sensation and neuropathy associated with the feet in individuals that have diabetes. And about half of all diabetic foot ulcers or wounds, that patient also has underlying PAD and they may not know about it. And that has really dramatic implications for wound healing and how likely somebody is to potentially need to have an amputation. So it's critical to be able to identify patients who are going to be at that greatest risk of PAD and its complications.
So what are some of those risk factors?
So, we talked about how PAD is oftentimes just cholesterol buildup in the blood vessels, the arteries to the legs. So similar risk factors to what we think of for heart and stroke health. And so I think there's been this shift in the vascular community to have all of us as clinicians think about our cardiovascular health as really being kind of three legs of this common stool. And so you have your heart health, your cerebrovascular health, which is putting you at risk for stroke, and then that peripheral artery disease or lower extremity vascular health, because they're all interrelated and those similar risk factors. So what are they? For PAD in particular, diabetes is a major risk factor. This has been known for many years. And then tobacco use. And those are by far and away the two strongest risk factors associated with developing PAD. But certainly things like high cholesterol, high blood pressure, just age, as we all age, that risk goes up. And then other issues that can affect somebody's development of calcified atherosclerotic plaque as well. But diabetes and tobacco use, age, high cholesterol, and high blood pressure.
So what are some of the symptoms of PAD? That someone may not be aware that they have it. What are some of the symptoms most common?
Absolutely. So it's interesting with PAD, we talked about this spectrum. So you have this kind of stable leg symptoms where somebody's impacted with how far they can walk or the level of activity they can do. And traditionally that's been called intermittent claudication. And that claudication refers traditionally to this cramping discomfort in one of the muscles in the leg that occurs when you're walking and then resolves when you are resting. The challenge is, even for that kind of stable symptom, so they're happening with exertion, that only happens about 10% of the time when individuals have clear, significant, flow limiting stenosis or cholesterol buildup in the arteries to their legs. So although that's a symptom we need to ask about, that won't capture the vast majority of patients who have symptomatic PAD. So what are some of the other symptoms? Well, oftentimes patients have some sort of other leg discomfort, whether or not it's a heaviness or a fatigue. Sometimes it can be discomfort that they have in their mind decided this is arthritis or it's neuropathy or it's aging. And so it can be more of a vague discomfort in the leg, and it can extend anywhere really from almost your groin area all the way down to your foot. And so many times patients will cut back on their activities so that they're not having this leg fatigue or thigh discomfort or back discomfort. And when they're asked about symptoms in their routine medical appointments, they'll say, I don't have any symptoms, but it's important to push that conversation a little further to really understand how active is somebody now and what could they do 6 months ago or a year ago. So we need to ask more broadly about limitations to walking, what somebody's really understanding what their functional status is, and asking about any symptoms that could be related to the legs. So that's that kind of stable exertional leg symptoms. Then we talked about this kind of sudden leg attack or the acute limb ischemia, and that is dramatic. Somebody has profound, discomfort in their leg. The foot can turn white or purple because they're not getting good blood flow down. The toes will be impacted, and that is generally speaking not subtle. Oftentimes, patients aren't aware that this could be what's going on. They may be thinking, is this a blood clot in my vein, but may not be aware that time is of the essence if you have lost blood flow in the artery to your leg or to your foot. And then that third group is that chronic critical limb ischemia, where you have just this tight cholesterol buildup and narrowing in one of the arteries to the legs, where you're day in and day out impacted by not getting good blood flow to that tissue in the foot or leg. And you're starting to see these kind of purplish black gangrenous toes, sores that aren't healing well. So PAD really runs that spectrum of having either asymptomatic, disease, where they aren't aware of any symptoms, but it cut back their activity, or in that same vein, not having enough of a narrowing that's impacted their blood flow, but fundamentally having cholesterol buildup in our arteries. It's that window into our cardiovascular health, that three legs of that stool. And so if somebody has underlying PAD, that's telling us that they're at a higher risk for heart attack or stroke, even if they're asymptomatic. So the kind of the take home point is you can be totally asymptomatic, having underlying atherosclerosis. You can have symptoms related to changes in your exertional or walking ability. You can have that acute limb ischemic event, that leg attack, and you can have that chronic critical limb ischemia, poorly healing wounds, or those kind of gangrenous toes.
Is it most common just in one leg, or will it occur in both legs most of the time?
That's a great question. It's for some patients, it's more unilateral and occurring in one leg, and for many people, it's a more of a systemic process. And so you'll have cholesterol buildup in more than one territory, one blood vessel territory in the leg, and involving both legs.
So how do you go about, as a cardiologist, how do you diagnose PAD?
So there are several steps to diagnosing PAD. I think the first one is having that conversation with a patient, taking the time to understand how active they are, and if they are having a limitation in how far they can walk. Because then your antennas are up that this may be somebody who could potentially have PAD. Second step is on that physical exam. And, it's having worked in Minnesota and in Florida, it's easier to oftentimes have patients not be wearing socks in Florida as compared to winter boots in Minnesota, but you need to check the pulses in the feet. So taking the socks off, taking the shoes off, and checking the pulses in the feet, because those are an important window that we can feel on physical exam to what's going on with that whole arterial tree that's going from our heart to the aorta and down to the arteries in our legs. So you need to do a good pulse exam. And you can check the pulses in the foot, behind the knee, listen for bruits, and in the iliac vessels, but really doing a good vascular physical exam. And then the third part is starting to get that diagnostic testing in. And the most common initial test that is done is something that's called an ABI, or an ankle brachial index. And what that is it's using ultrasound and blood pressure cuffs to really non-invasively look at blood flow in the leg compared to that in the arm. And so you're checking that blood pressure in your arm and comparing it to a series of blood pressures taken in the legs using blood pressure cuffs as well as ultrasound. And that's a very straightforward, not expensive test to determine if somebody has evidence of PAD. There's certainly some limitations to doing the ABI testing, but that is absolutely a very helpful first test to do. And then when you're diagnosing PAD and you're having to make some of those decisions about, are we going to use medications and exercise, diet and lifestyle to treat PAD, or do we need to focus more on a revascularization? That's where things like CT scan or an MRI, where you're using dye to get these non-invasive angiography images, to get a roadmap of the vessels and to potentially plan for intervention. And then certainly you doing invasive angiograms sometimes needs to happen if you need to get a more complete picture of the arterial tree, and you can't do it non-invasively. Or if you're aiming to do a balloon or a stent, you get that diagnostic information as well as being able to do the procedure at the same time.
So how do you treat PAD?
Well, there's several parts to treating PAD. we need to think about the risk factor modification. So traditionally, patients with PAD have not been put on really life-saving medications the same way we have treated patients with, or learned to treat patients who have coronary artery disease or a history of cerebrovascular disease. So unless there's a contraindication, patients who have PAD have, obviously this known vascular disease now, and we need to reduce their risk of heart attack, stroke, and acute limb ischemic events or leg attack. So using an antiplatelet, something like aspirin. Second part of that risk factor modification would be aggressive lipid lowering. So if that involves a statin, or if their cholesterol is not getting to goal on statin, adding additional cholesterol medication. And we now have good data about the role of some of the injectable cholesterol medications, the PCSK9 inhibitors, the monoclonal antibodies, have been well studied at this. So we talked about aspirin lowering cholesterol, really making sure that diabetes is well controlled. And if it's something that we need to adjust their medications or insulin to be more aggressive, or just really amplifying what's being done from a diet and exercise weight loss perspective, diabetes control is critical. Controlling blood pressure, and then really counseling and finding those pathways that are going to help them stop smoking if they still are using any nicotine products. So that's going to be kind of the cornerstone of the medical management of those cardiovascular risk factors. The other parts, which are not to be forgotten, are the importance of diet and exercise. So there was a Spanish study, the Predimed study, that came out almost 10 years ago now, that looked at Mediterranean diet. And it can actually reduce your risk of developing symptomatic events with PAD. So what we eat matters. Mediterranean diet, all those good omega-3 fatty acids, that matters. The other part is the exercise. So this can be hard for patients to really wrap their head around if part of how they got to this diagnosis of PAD was because they were having a hard time exerting themselves or walking because of symptoms. But supervised exercise therapy, or SET, that's been approved and covered by Medicare for patients who have symptomatic lower extremity PAD, really as a first-line treatment, oftentimes even before considering revascularization, because it's so successful. And what this involves, you can think about it almost like cardiac rehab, but leg artery focused. And the exercises are somewhat similar, but if you're having discomfort in your legs or inability to walk because of this PAD, then what the SET teaches you to do is that you essentially walk, or there's even data about doing arm ergometers if you have an amputation or can't walk, but you're doing some exercise and you do it until you have to stop because of symptoms or fatigue. You reach this ischemic threshold, then you rest. There's a protocol for this that's nicely laid out by many colleagues, but Diane Treat-Jacobson has been a senior author in this field for years. So there are guidelines for how to do SET for hospital programs and rehab programs. But fundamentally, this idea is that you're exercising until you need to rest, then you stop, rest, let the discomfort die down, and then you get going again and keep doing it. And you work up to being able to do this for about 45 minutes at a time. And what is amazing to me as a cardiologist is that your body can actually develop new blood vessels, new collateral vessels, new pathways around, and it changes your body's production of these critical factors like nitric oxide that can help cause this vasodilatation in your smooth muscles and that line their arteries, as well as impacting that endothelial health. So exercise has been well shown, particularly in this very pivotal study called the CLEVER trial, that looked at randomizing patients who had real PAD, symptomatic, abnormal ABI, and were randomized to just getting medical therapy, essentially the risk factor modification medications we talked about, supervised exercise, or having a stent put in their aortoiliac lesion. And data was published at 6 months and then again at 18 months. And ultimately, someone's ability to walk on the treadmill, it didn't really matter if you had the supervised exercise program or if you had the stent put in, which is a surprise. So not that there's never a role for stents. There absolutely are roles for stents or lower extremity bypass surgical procedures. But I think studies like the CLEVER trial really underscore the importance of the exercise program, in particular the supervised exercise program. So it took a lot of work from many stakeholders over the course of years to lobby for having this be covered, but it was covered, I believe, starting in 2017.
Wow, that's fascinating stuff. What information do you think is particularly important for patients that they should share with their medical team or their clinician?
I would say that for patients, if you have risk factors for lower extremity PAD, diabetes, tobacco use, high cholesterol, high blood pressure, and then just as we all age, it's really important to have those conversations about your ability to exercise or walk. And if you are having any limitation, to talk about that with your providers. The other part that I think is really critical is that we understand as healthcare providers as well as patients is that there are very important health disparities that have a dramatic impact on patients with PAD that we need to continue to talk about, to raise awareness, and then to change. So there is an amputation epidemic. And I don't use that word epidemic lightly in today's climate. I use it intentionally, because depending upon where you live in our country, you may be at a higher risk of having an amputation for lower extremity PAD and not always being offered a revascularization procedure because PAD, maybe the providers weren't looking for it before an amputation was recommended. We know that Black Americans are disproportionately affected by PAD compared to white Americans or Hispanic Americans. Hispanic Americans tend to present with more advanced PAD than white Americans. It's also important to raise awareness about PAD for individuals who are Native American or Asian American. So there is a lot of work that needs to be done with awareness of PAD and these critical health disparities. PAD is really set to triple in the United States in the coming years. And so we have an important opportunity to not only prevent that from happening, but to prevent heart attacks and strokes, to help people live longer lives with a greater degree of functional ability by diagnosing and treating PAD. So I think when it comes to the health disparities, we need to be doing even more outreach to populations that have been historically not focused on, with that important information about what PAD is, how it can present, and what treatment options there are.
Why do you think PAD isn't as well known and diagnosed later compared to some of the other cardiovascular conditions?
I think PAD traditionally, I'd say traditionally for PAD, I was in medical school about 20 years ago, and at that time, kind of the prevailing thought was that PAD was, generally speaking, a much more stable process, and I don't think we knew as much about that dramatic risk that PAD has in terms of somebody's future risk of cardiovascular events. There's about a 20% risk of having a heart attack when you are diagnosed with PAD. Again, because of that underlying tie-in with that systemic atherosclerosis for many patients. And I think that PAD is, frankly, it's just hard to say. It's hard to wrap your head around it. I mean, it's even the phrase itself, peripheral. I mean, it sounds like it's something that's not that important. It's not a central artery disease. It's a peripheral artery. So I think as one of my colleagues and one of our co-chairs for the National PD Action Plan Dr. Aruna Pradhan from Brigham and Women's Hospital, as she coined the phrase, PAD has a PR problem. And she's right, 1,000% right. And that's really what so many of us are continuing to work on to try to address, is that PR problem. And it may very well be that as we continue on this path, what is now called PAD may need a catchier name to really have the weight and the importance with these conversations with patients and providers, amongst community members, because PAD is a deadly disease. It is deadlier than many cancers that we are familiar with. And it's not to say one disease entity is more important or less important than others, but I think particularly in today's day and age, where there's so much information about our health that we can have on our apps and patient portals, understanding that PAD exists, how it may be important to a given person in terms of their risk factors and symptoms, that's something that we have to move the needle on. And we need to do better at getting that word out to patients at the greatest risk. So individuals in different regions of our country, particularly the Southeast, folks who are at the highest risk of amputation, in particular, Black Americans, we need to end this amputation epidemic.
So PAD needs a rebrand, is what you're saying.
It does. PAD needs a rebrand. And I'm really thankful to be able to volunteer with the American Heart Association and to have been able to work as a co-chair for the development of the National PAD Action Plan. As I mentioned, with my co-chair is Dr. Aruna Pradhan and then Dr. Naomi Hamburg. And AHA, the American Heart Association, has been the convener of this work. But what is so exciting to me and the group of us working on this is that it's a multi-stakeholder initiative. It's not just one organization or even one specialty. We have had committed volunteers from 25 organizations that have been working on this really actively since about 2018. And that's on the heels of decades of work that have gone before that from many of our colleagues. So there are a lot of stakeholders involved, from vascular surgery, interventional cardiology, interventional radiology, from wound care, from cardiac rehab, from so many nursing and advanced practice provider organizations, patient advocacy groups like Vascular Cures and Women Heart, and then importantly, governmental organizations like the NHLBI and CDC, as well as our fellow cardiology organizations, American College of Cardiology and Society of Vascular Medicine, Vascular Nursing, and so many others, not to leave anyone out. But I think that gives you a flavor for just the breadth of individuals that are coming together. And we want to really galvanize this passion for vascular health awareness and to have that tie in with the tremendous work that our colleagues in internal medicine, primary care, and family practice are doing. And that's a gap that we still need to bridge because PAD, many times patients aren't getting to a specialist. So we need to really increase that awareness and make it easier to detect PAD in patients who are at the greatest risk and who may have undiagnosed PAD. Where one of my colleagues at the American Heart Association, Dr. Beckman, who's the head of vascular medicine at Vanderbilt, he loves to do the battle cry of take off the socks. And that is such good advice. Taking off the socks, checking pulses. If somebody has exertional leg symptoms, an abnormal pulse exam, or poorly healing wounds on their foot, doing an ABI test. And this is really critical. Doing an ABI test in that scenario, it's a diagnostic test. That's absolutely appropriate and is not controversial in terms of the US Preventative Task Force recommendations. Where I think some of this diagnosis of PAD got muddied is the USPTF gives screening broad populations of individuals for PAD without any associated symptoms or abnormal pulse exam. They give that an indeterminate rating. I think that's a whole nother conversation about hopefully being able to show evidence that screening for PAD in high-risk patients who are asymptomatic can help improve outcomes. But that's a different discussion. And so for the purposes of our talk today, if somebody has exertional leg symptoms, if they have decreased pulses on their feet, if you're worried about critical limb ischemia with poorly healing sores, diabetic patient who has a diabetic foot ulcer, that's something where PAD is a diagnostic test, not a screening test. And we need to do that to be able to identify patients who would be at risk for limb loss and amputation, or who just by diagnosing PAD, you can help then prevent heart attack and stroke and improve their quality of life, where they can live longer, stay in work longer, have those memories with their family, and be able to provide for their families without having PAD go undiagnosed and then take that away.
Well, unfortunately, we're all out of time, but hopefully today's podcast will help us raise some more awareness to PAD for folks around the country, so we can raise even more awareness about this condition. We want to thank our guest today, Mayo Clinic cardiologist, Dr. Amy Pollak. Thank you so much for joining us today. It was a pleasure.
Thank you for having me.
Raising awareness about peripheral artery disease. Thank you so much, and thanks everyone for listening and watching. See you at the next episode.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.